Today I'll be presenting a paper on demographic and clinical profile of intimate partner violence related ocular injuries. I cannot move the slide.
The slides.
Intimate partner
Please.
violence is one of the most common and underrepresented forms of violence amongst women, with rates up to 10 to 69%. These account for 34 to 73% of facial trauma, out of which 94% involve the head and neck region and 45% involve the eyes. However, poor detection rates, limited evaluation in the ER, and a comprehensive lack of research results in the underrepresentation of IPV injuries. This study aims to identify demographic and clinical risk factors for IPV in India and correlate them with visual prognosis, and to draw out a predictive model to assess the severity of ocular injuries based on the demographic profile of the subjects. This is a retrospective cross-sectional ER-based study conducted over a course of 1 year, and analysis was done to draw out the demographic and clinical correlations between the ocular injuries and demographic variables. Inclusion criteria included patients with a history of IPV who had not received prior treatment or had not been reviewed previously for these injuries. Patients who were also reviewed only for the first time and had given prior informed consent. Exclusion criteria, patients with other associated traumatic history, injuries with prior history of IPV injuries, or were on systemic treatment for other bodily injuries. The information was adequately analyzed, and the results are as follows. 54% of the patients were in the age group of 30 to 40 years, with the mean age being 30 years. Younger age groups had higher BCVAs, and the maximum rate of IPV injuries was noted in Prasad Economic Scale 4. This is the graph that showed the age and the demographic profile against the visual acuity. The ocular injuries was found to most commonly involve the conjunctiva, followed by eyelid and vitreoretinal injuries. 65% of the IPV patients presented within 7 days of injuries, among which 47% were in the Prasad scale 4 and 73% in the age group of 30 to 40 years. 87% of patients less than 20 years of age reviewed after a period of 7 days. 65% were treated conservatively, 13% needed repair of open injuries, and 21% were patients with guarded visual prognosis who refused to go to a higher tertiary center for adequate surgical repair. A logistic regression model was made to evaluate the visual prognostic outcomes, where age, socioeconomic status, and injury interval were found to be significant in determining visual outcomes. We developed a nomogram score wherein we gave a score to injury interval, socioeconomic status, and age, and we had a cumulative score from 0 to 11. Based on the score, we developed a scale of probability for guarded visual prognosis. The ROC curve was plotted, and which showed a sensitivity of the model of 82.73%. Existing research identifies demographic, societal, and clinical characteristics which help to estimate the prognosis of IPV injury. Current study estimated mean age to be 30 years, which corresponds to different other studies which were conducted outside India, while nearly 40% of patients in the higher socioeconomic groups had good visual acuities. Lower socioeconomic groups had injuries that were more visually threatening. Majority of the IPV injuries affected the conjunctiva, followed by eyelid injuries and vitreoretinal injuries. 65% of victims presented within 7 days. Adequate access to healthcare services has been favorably linked with final visual acuities. The current study also established that injury interval, age, and poor socioeconomic state were inversely proportional to visual prognosis. As we showed before, the predictive nomogram was evaluated, and this can also be used as a triage model in ED settings. The model also helps to identify, screen, and determine IPV victims based on the injury interval and demographics, and helps in evaluation and further referral for ancillary services. IPV injuries continues to be an important cause of ocular trauma, but is severely limited by inadequacy of detection, assessment, and appropriate referral. Early and efficient intervention can aid in appropriate management. Association with demographic risk factors can further help to detect recurring patterns of injury. Limitations of my study were, this study included documented IPV cases, and as mentioned before, IPV is severely underdiagnosed in ER settings. The sample size did not include any male patients, and the sample size did not include subjects from higher socioeconomic strata, and obviously only the patients who had given consent were included in this study.
You have a very limited subset of patients. Your data is
Yes, sir.
greatly skewed to one side.
Yes. That was one of the limitations of my studies, sir.
Any other comparative studies earlier?
So I did two comparative studies. They established that these factors were linked, but they did not make any predictive model or did not have any scoring system based on it. So,
Yes.
studies pertaining to Indian scenarios are very limited.
And your study shows all females, no males. No.
Yeah,
And
I did not have any male patients. I did not have that as an exclusion criteria, but I did not get male patients.
So is it a global phenomenon or it's?
So it is not a global phenomenon because most of the studies that I have as my references, they did contain male patients. But in my case, I did not have that as an exclusion criteria, but I still did not get it. So.
Thank you.